Yeah.
Yes,
Ma'am,
ma'am.
you can start, ma'am, please.
Okay. Good evening, everyone. It's my pleasure to welcome you all for this BODHANA series, PG case discussion, which has been started last year by our dynamic Vice President Fogsy and also Secretary of TNFOG, Sampath Kumari Madam, along with Anjalakshi Ma'am, our first founder president of TNFOG. This has been continuing leadership of Revati Janakiraman Madam, who is the current President TNFOG, and under the guidance of Secretary General Sampath Kumari Ma'am. Today we have interesting topic infertility, which will be discussed extensively by our learned teachers. We have our learned teachers and who can share their experience here, which will be really useful for the PG students. It's my pleasure to. Do we have our president or secretary to deliver welcome address? Shahiti, Priya?
No, ma'am.
No, ma'am. No, ma'am. You can start,
Okay.
ma'am. You can introduce and start.
Because our president is also busy with some other webinar. Madam will be joining shortly. Our secretary is out of station and she is in another Fogsy conference. So let us go ahead with the program. It's my pleasure to invite Krishna Kumari ma'am, who is the Chief Civil Surgeon, Government Headquarters Hospital, Kanchipuram. Welcome, ma'am. Our next examiner is Anita ma'am, who is a Senior Assistant Surgeon, Government Headquarters Hospital, Kanjipuram. Madam has done UG at Madras Medical College, DGU at Madras Medical College, and MSOG at Theni Medical College. Welcome, ma'am.
Yes, welcome, madam. Good evening. Is
Good
audible,
evening,
ma'am?
ma'am.
Yes.
Yes, you're audible, ma'am.
Yes.
Our
Yes, ma'am.
next examiner is Madam, who is very close to me, well known to me, my senior in Tirunelveli Medical College and now President Tirunelveli UG Society. Madam is the professor in OBS Gyne, Tirunelveli Medical College. Uh, she was the past secretary of Tirunelveli UG Society for 5 years, conducted many workshops, live workshops and gynec workshops, presented many papers, received Best Paper Award in UFOGZ 2. She has been national faculty for years together. Welcome, ma'am.
Thank you, Dr. Kappada.
I think your voice is so bad. Sorry to
Oh,
trouble you so much, but it is
no
our
problem.
pleasure to have you here,
Okay,
ma'am.
okay. I'll try my best.
Yes, ma'am. Our next examiner is Dr. Shuganti ma'am, who is a professor, OG Department, Institute of OG, Madras Medical College, and madam has done MBBS in Madras Medical College, MD and DGU from Madurai Medical College. Madam is a member of IAGE and she has got rich experience in teaching, almost 20 years of teaching experience, trained in laparoscopy and colposcopy. Madam's interest is reproductive endocrinology and infertility. Welcome, ma'am.
Good evening, madam. Thank you for the nice introduction.
Thank you, ma'am. I'll just invite the students also,
Yes.
PGs. The presenter now today is Dr. Nandini, who is a second year dependent candidate doing in Government Headquarters Hospital, Kanchipuram. Welcome, Dr. Nandini. The co-presenter is Dr. Radhika, who is a final year PG dependent student, and she is also doing her PG in Government Headquarters Hospital, Kanchipuram.
Good evening,
Over
ma'am.
to you, examiners.
Yes, I think you can start presenting.
Good evening, ma'am.
Yes, you can go on, Ma.
From Mr. X, 27-year-old female, married since 2 years, nulli gravida, who is a resident of Kanjipuram, educated till 12th standard and tailor by occupation, belong to class 2 socioeconomic status. She came to OPD with complaints of 2 months of amenorrhea and she is anxious to conceive, ma'am. History of presenting illness.
The slide is not changing.
Yes, ma'am. History of presenting illness. She came to OPD with complaints of 2 months of amenorrhea and inability to conceive in spite of regular and productive sexual intercourse with married life of 2 years, ma'am. No history of previous evaluation and treatment for the same. It's the first time she came to OPD for the evaluation of infertility. History of UPT done 2 days back at home and found to get negative. And she had a history of irregular menstrual cycle for past 4 years, ma'am. Other histories like she had a history of acne.
Okay,
And,
we'll
no-
stop here. 1 minute, Dr. Nandini.
Yes, ma'am.
Does she have a knowledge of the fertile period? And because she's married for 4 years, she's married for 2 years, is it?
2 years, ma'am.
Okay. So is she aware of the fertile period?
Another asking fertile period.
Yes. Did you
Patient
elicit
is
her
not
history?
aware of.
Yeah, that is important, no? Because she's educated till 12th standard. I don't know, probably will she be aware already she has irregular periods? In case a patient has irregular periods, now she comes and asks you about the fertile period, when she should have coitus, how do you counsel her?
Actually, first I will regularize her cycle with OC pills, ma'am. And I will do baseline investigation, ma'am. I will inform her that her fertility window will be from day 10 to day 17 of the cycle, ma'am.
But she has irregular cycles, no? For the past 4 years.
First,
Even before marriage, she has irregular cycles, is it not?
first I will prescribe
And
her,
actually, she had a regular cycles, ma'am, from menarche. Only for past 4 years, she is having irregular cycles.
Okay. So you want to regulate a cycle and then you have to talk about the fertile period and have coitus during the fertile period, right?
Yes, ma'am.
Okay. And history of acne, what does it indicate?
From hyperandrogenism, ma'am.
Yes. Okay, so you should look for other features of hyperandrogenism also. That could be the cause of the irregular menstruation also, right?
Yes, ma'am.
Yes, ma'am.
Okay, go on.
No history of excessive facial hair growth or body hair growth. No history of abnormal discharge per vaginum. No history of burning micturition, lower abdominal pain or backache. No history of
We'll
intermenstrual
stop
bleeding.
here 1 minute. Go to the previous slide. What is the Turner's classification of hair distribution?
Tanner staging of hair distribution has four stages.
Staging, ma'am.
Stage 1 is pre-pubertal, ma'am. No hair distribution over the genitalia, ma'am. Stage 2 is fine, mildly pigmented hair distribution, ma'am. Stage 3 is coarse pigmented hair distribution, ma'am. Stage 4 is adult type of hair distribution, ma'am, including the external genitalia and an inner aspect of thigh, ma'am.
Okay, go on.
No history of intermenstrual bleeding. No history of postcoital bleeding. No history of dysmenorrhea or
Why did
dyspareunia.
you ask this history of intermenstrual bleeding or postcoital bleeding?
Intermenstrual bleeding will signify the patient if had any endometrial polyp, ma'am. It will present with intermenstrual bleeding.
Endometrial polyp or submucosal polyp?
Submucosal fibroid also, ma'am.
Yes. So submucosal fibroid will cause more of intermenstrual bleeding. And postcoital bleeding? This
If
age,
there is any local lesion in the cervix or
what is the age of the
pre-invasive
patient?
lesions,
What is the age of the patient?
27, ma'am.
Okay.
What do you think is the cause for irregular periods?
Ma'am,
What is the cause of irregular periods? Why she's
Why
getting
the
irregular?
patient has irregular period? Madam wants to know why she has irregular periods.
What's the reason?
Maybe due to anovulation, ma'am. Patient is obese and she's having features of hyperandrogenism.
hyperandrogenism.
Maybe due to PCOS also.
What do you want to say? It is PCOS? Do you want to say it is PCOS?
The patient is a known case of PCOS, ma'am. For past 2 years, she's taking on medication, ma'am.
What medication?
She took tablet metformin alone for 6 months, ma'am. Then she discontinued the treatment, ma'am, after
What
marriage.
is the criteria for metformin in PCOS?
The BMI should be
glucose tolerance and high BMI.
What is the criteria for PCOS?
Rotterdam's criteria, ma'am.
Features of
What's the criteria?
hyperandrogenism.
Oligo-ovulation or amenorrhea, ma'am. The second one is clinical or biochemical features of hyperandrogenism. Clinical features like acne, hirsutism, and androgenetic alopecia. And biochemical markers like increased, raised serum testosterone, diandrostenedione, DHEAS, like that, and ultrasound features like more than 20 peripherally arranged follicles, size about 2 to 9 mm, and volume is more than 10 ml.
What ultrasonogram will you ask for to measure these 20 follicles? It is 2D or 3D?
Transvaginal ultrasound, ma'am.
2D or 3D?
Using probe of 8 megahertz, ma'am.
No, you want 2D or 3D? Which is accurate? Where is the criteria now changed?
Ma'am, it is actually 3D
Ultrasound, ma'am. We can also look for the increased blood flow around the follicles, ma'am.
Okay, so now it is the 3D where we can accurately measure 20 follicles. Okay. So you
Yes,
say
ma'am.
this patient is having anovulation.
Yes, ma'am.
Okay, proceed.
Okay, what is the WHO classification of ovulatory dysfunction?
Ma'am, class 1 is due to hypothalamic failure, ma'am. Any defect in hypothalamic axis, ma'am. Class 2 is due to insulin resistance or PCOS, ma'am. Class 3 is primary ovarian failure, ma'am. Premature menopause, like that. Turner syndrome, sexual dysgenesis, all those causes will come under WHO class 3, ma'am.
So your patient is in class 2.
Yeah,
Yeah,
ma'am.
ma'am.
Okay.
Go on.
No history of dysmenorrhea or dyspareunia, no history of chronic cough, evening rise of temperature and weight loss, no history of weight gain, hair loss, cold intolerance and constipation, no history of strenuous exercise, abnormal eating pattern, headache, visual disturbances, no history of vaginal dryness, hot flushes, no history of any nipple discharge.
Okay, if this patient comes with, go to the previous slide. You
Yes,
said no history of dyspareunia and dysmenorrhea. If she comes with dyspareunia and dysmenorrhea, what will be your probable diagnosis?
Maybe due to PID or endometriosis.
endometriosis, ma'am.
What are the types of dyspareunia?
Primary and
Primary,
ma'am.
secondary, ma'am.
Primary is due to local lesions in vulva or vagina, ma'am. Secondary is due to other pelvic pathology like adenomyosis, PID, or endometriosis.
Okay, so if
What
the
do you call
patient has
that
a
as?
deep dyspareunia, then
Deep-seated dyspareunia, ma'am.
Deep dyspareunia. Okay.
Okay. Why did you ask for vaginal dryness and hot flushes?
Premature
Premature ovarian
ovarian
failure.
Okay, go on.
Then menstrual history. She attained menarche at 13 years of age, ma'am. She had 4 by 35 days regular cycle. She used 3 to 4 pads per day, ma'am. But for past 4 years, she had an irregular cycle with once in 45 to 60 days cycle, moderate flow, ma'am. She using 2 pads per day, not associated with clots. No history of painful maturation, ma'am. Her last LMP is 21/2023, ma'am.
So for the past 4 years, for the irregular cycle, she was not treated.
Ma'am, a patient
Diagnosed with PCOS and she took metformin for past 6 months, ma'am. There was non-compliance of treatment and she discontinued the treatment, ma'am.
She took only metformin.
Yeah, ma'am.
metformin alone, ma'am.
Okay. Okay, go on.
Marital history, she got married since 2 years and she is living with her husband. Non-consanguineous marriage, ma'am.
Okay.
Coital history, patient is not aware of
What else you
fertile
should,
period.
yeah, what else you should ask in the marital history apart from living with the husband? How about extramarital relationships? Is it important?
A multiple sexual partner or extramarital relationship, there is a chance for PID, ma'am.
Yes,
Chlamydial
PID and
infection.
STDs are more
What ab-
common, no?
Yeah, ma'am.
So that is also important. Okay.
Okay.
Yes,
Right.
ma'am.
Okay.
Then coital history, the patient is not aware of fertile period and its significance, ma'am. Coital frequency is 2 to 3 times per week without any use of contraception and no lubricants used, ma'am. No history of coital difficulty and no history of painful coitus. No history of erectile dysfunction, ejaculatory failure. No history of decreased libido or no history of premature ejaculation or cloudy urine post coitus, ma'am.
Can you differentiate erectile dysfunction and ejaculatory dysfunction? What is the cause? What is the difference?
Ejaculatory failure is mostly due to post-testicular obstruction, ma'am. Erectile dysfunction is mainly due to psychological or nervous system failure.
So erectile dysfunction is it's mostly psychological or
Yeah.
some neurological. Ejaculatory disorders, can you give some examples? Ejaculatory dysfunctions, which is very common. If you what history will you ask? Any premature ejaculation, any retrograde ejaculation. So you have to ask about the ejaculatory abnormalities also.
Okay.
Yes.
And all erectile dysfunctions also. Can you give some drugs which can cause drugs which can lead to such dysfunctions?
Ma'am, anti-androgenic drugs like cimetidine, spironolactone can cause erectile dysfunction. Ma'am, beta blockers can also cause erectile dysfunction. Ma'am.
Okay, some common drugs, day-to-day usage. Temporarily they can cause.
Huh?
Even antibiotics.
Common drugs that will cause sperm defects, doctor, like your antibiotics and all that.
Okay.
And
What are
drug
the
abuse
drugs which
also.
causes, which affects the spermatogenesis?
You have to also ask about the drug abuse. They can be
Okay.
taking some abusive drugs. So drug is very important. Antipsychotics, antihypertensives, so very common. Antibiotics, some few antibiotics, doxy and nitrofurantoin, they can temporarily affect. So you have to ask a detailed history about the drug intake.
Commonly used drug, no, like nitrofurantoin and all that for UTI. Okay, and then for gastritis, when you use ranitidine and all that also will affect the spermatogenesis. So drug history is very important. The patient might not come out with those histories. Right. Why did you ask for cloudy urine post-coitus?
Retrograde ejaculation, ma'am.
Okay. Okay, go on.
History of male partner, ma'am. Her husband is 39 years old. He is a daily wage worker, not a known alcoholic, not a known smoker or pan chewer. No history of any substance abuse, no history of trauma to the genitalia in the past, no history suggestive of mumps in the childhood, and no history of exposure to sexually transmitted diseases, and no history of any chronic medical illness, diabetes, CKD, liver disease, tuberculosis, or recurrent URI and bronchiectasis. No history of chronic drug intake, and no history of any inguinoscrotal surgery done in the past. No history of delayed developmental milestones or poor school performances, ma'am.
Okay.
So what
Next,
past
past
history
medical.
did you specifically ask to the male? What past history did you ask specifically? Tuberculosis other than that?
Tuberculosis, diabetes,
Okay, the childhood bumps, then
childhood mums.
Childhood mums, ma'am.
any undescended testis
Scrotal
corrected?
surgery. Yeah, ma'am.
Any
Scrotal
any
surgery.
undescended testis which was corrected? What is the ideal age to correct an undescended testis?
Ma'am, recent guideline is less than 6 months, ma'am.
So should be less, but many correct it after 2 years. So that can be one of the reason. So you have to ask about all those surgeries. Any other surgery?
Yes, ma'am.
Ma'am, hernia repair, ma'am.
Okay,
It
why
can
hernia
cause
repair
nerve
causes?
damage and can lead to
What nerve
erectile
damage?
dysfunction or ejaculatory failure.
What nerve is damaged?
Ilioinguinal nerve.
Ilioinguinal nerve
Yeah, ma'am.
and the genitofemoral. Okay, so
And
these can lead
genitofemoral
to
nerve.
some. Any other surgeries?
Surgical repair for varicocele or
Testicular
So,
torsion.
testicular tumors, any testicular varicoceles. Okay, so these surgeries and drugs very, very important. And childhood, any undescended disease which was operated late, that also you have to ask. Okay.
Yes, ma'am. Okay, ma'am.
Go on, doctor.
Past medical and surgical history, ma'am. She is a known case of PCOD per past 2 years back. She was treated with tablet metformin 500 mg BD, and patient non-compliant and stopped the treatment after 6 months, ma'am. No history of diabetes, hypertension, tuberculosis, sexually transmitted diseases, thyroid disorder, renal or liver diseases. No history of previous surgeries or invasive procedures. No history of radiotherapy or chemotherapy, ma'am.
What previous surgeries you asked for?
Ma'am?
What previous surgeries you asked for? You say no history of previous surgeries. This is for the
Previous history of any laparoscopic ovarian drilling or like previous ectopy history or tuboplasty like that. No?
Okay. Go on, doctor.
Personal history. She takes mixed diet and no history of substance abuse. Normal bladder and bowel habits, ma'am. Sleep and appetite are normal, ma'am. Then family history. No family history of infertility or premature ovarian failure. No history of diabetes, hypertension in the family members, ma'am.
Did you ask for sibling history, whether she has children and all that? How about sibling history? Is she a single child or she has siblings with children?
We have only one brother, ma'am.
Okay. He's got children? Okay, so she doesn't have a sister. Okay, right. Okay, go on. Yes.
General examination, ma'am.
So from the history, what is your probable diagnosis?
From the history, my probable diagnosis is anovulation.
Anovulation.
Mainly due to PCOS, ma'am. As patient has features of anovulation,
Hyperandrogenic features.
Overweight, ma'am. Obesity also.
So what is the age of the husband? Age of the husband?
29 years. Ma'am.
Her husband is 39 years old, ma'am.
39. So any
Yes, ma'am.
significance? Any significance of this age?
In me,
The male age have poor quality of sperms, ma'am.
After what
There is
age?
no chance.
after 50 years of age, ma'am.
So after 40, the infertility rises in male. In female,
After 35 years, ma'am.
okay. So after 50, it drastically increases. So this why?
Yes, ma'am.
What is the reason for this age difference? Did you ask?
Ma'am?
What is the reason for the age difference? Any significant factor, first marriage or second marriage? Why the difference in age
The
between?
first marriage, ma'am.
Yes.
First marriage,
marriage, ma'am.
non-consanguineous marriage only. ma'am.
Okay. So now your diagnosis is an ovulation.
Yes, ma'am.
So how we are going to proceed?
Can you repeat
How
the
we are
question?
going to proceed?
What are you going to do for the patient, doctor? How are you going to investigate? How are you going to counsel the patient? Initially, we have to counsel, no? What all counseling will you do?
First, I have to consult the patient regarding she is more obese, ma'am. So I have to consult regarding the weight loss and lifestyle modification, ma'am, and counseling about the fertile period, ma'am.
What is the weight
How-
of the patient?
Excuse me. How lifestyle modification? What advice you give? How it reduces or brings about the ovulation?
Actually, in obese patient, due to insulin resistance, there is more chance for anovulation, ma'am. And due to peripheral adipose tissue, there is peripheral conversion to estrogen, ma'am. There is hyperestrogenic state, ma'am. So weight loss helps in restoring the ovulation, ma'am. Weight loss of 10 to 15% can regain the ovulation in 50 to 75% of the patient, ma'am.
So at least a 5 to 10% weight loss can resume ovulation in 15% cases. Okay. So you have to advise any other lifestyle modification.
Calorie restriction, ma'am. Energy restriction of 500 to 750 kilocalories according to the individualized calorie requirement of the patient helps in weight loss, ma'am. Then moderate intensity exercise of 150 minutes per week or a high intensity exercise of 75 minutes per week for weight maintenance, ma'am. For weight loss, it is 250 minutes of moderate intensity exercise per week or 150 minutes of high intensity exercise per week, ma'am.
Suppose she is
Helps in weight
morbidly
loss.
obese, will you offer some other
We can
thing?
give early start or drugs help,
Fine. Will help, ma'am.
sibutramine, which helps in weight reduction, ma'am, or she can opt for bariatric surgeries too, ma'am. If
So that is
medical
also one
treatments is-
fails. Last resort. Okay.
Yeah, ma'am. Yes, ma'am.
Yes, you proceed. What are the things you are
Generally-
going to do?
Apart from weight reduction, what are the other counseling? What else you will do? Has the husband undergone a semen analysis?
No, ma'am.
No, ma'am.
The first visit of the couple to our hospital,
Then
ma'am.
none of, I mean,
Only
are
we
not
are going to
investigating.
evaluate.
So what else you will tell? Like when the counseling apart from weight reduction, will you not tell about that both the partners should see you together and undergo the investigations that you write?
The couple is unaware of the fertile period also, ma'am. So we will give counseling about the importance of fertile period.
Yes.
Will you
And
not ask about semen analysis? Why?
Ma'am?
Why you don't ask about semen analysis? Semen analysis, why you don't advise?
Semen analysis we should
This
do.
is the first time the patient visiting the clinic,
So
ma'am.
first time itself, we should counsel and we will take semen analysis in first visit, ma'am, to rule out any male factor, ma'am.
So the first easy investigation, non-invasive. So it is rules out
Semen
many
analysis.
things. So semen analysis, you have to counsel and ask for a semen analysis. That will be,
Yes,
that rules out many things. Can you tell the recent guidelines of semen analysis?
Ma'am, WHO 2021 guidelines, ma'am. The minimum amount of sperm quantity is 1.4 ml,
ml,
ma'am. Normal morphology sperm is 30.
Total sperm per ejaculate 39 million per ml, ma'am. And sperm concentration should be 19 million per ml, ma'am. The normal progressive motility at least should be 42%, ma'am. And normal forms should be at least 4%, ma'am. The WBC count should be less than 1 million per ml, ma'am.
What is the total motility? How much percentage?
Ma'am,
Total motility.
Total motility should be
Total
42%.
42%, ma'am.
So total motility 42, progressive should be,
Progressive 30, ma'am. 30%, ma'am.
so progressive at least 32%. This should be at least 40%. What is the sperm concentration? You said 19 or 15?
Sperm concentration.
Sperm
Concentration 16, ma'am.
16, ma'am. 16 million.
So it should be 15 million per ml. Do you have any idea about total motile sperm count? Total count is 39
And
million.
total motility.
Total motile sperm
motility is
count.
42%. ma'am.
No, total motile sperm count. Do you have any idea?
Total motile sperm count. What should be
This
the
also
total?
has a significance. From the motility and concentration, you have to multiply and you can get the total motile sperm count, which is also now taken as very important to assess the fertility. Okay, any other parameters you want to give importance?
When you say oligospermia, how do you classify the oligospermia now, the latest guidelines?
Oligospermia is sperm count less than 39 million per ejaculate. ma'am. Total sperm count less than 39 million per ejaculate.
You have to tell with this concentration, no?
Concentration is less than 42%. So less
No,
than
sperm.
16. ma'am.
See, sperm
than 60.
concentration is 15 million per. So what is oligospermia?
Huh?
What is severe oligospermia?
Severe oligospermia, sperm count less than 5 million. ma'am.
Then what is moderate?
What is moderate, what is severe, and what is mild?
Mild.
That's how
You have to
you
come in the reverse order, I think.
Ma'am, mild is 10 to 15. ma'am.
Okay,
Moderate
Moderate
is
5 to 10.
5
So,
to
how
10.
will-
ma'am.
So
Severe
when
is
will you
less
define
than 5.
oligospermia? Less than 15 million, you define it as oligospermia.
Yes, ma'am.
Sperm concentration, okay.
Okay, ma'am.
What is asthenospermia and teratospermia?
Asthenospermia is sperm having abnormal motility is called as asthenospermia. ma'am.
What is tetraspermia and necrospermia?
Ma'am? Tetraspermia is abnormal morphology, ma'am. Necrospermia is sperms in semen. ma'am.
Okay. What is CASA?
Ma'am,
CASA, C-A-S-A.
Sperm automated
Computer.
Yes, computer.
Computer assisted. That is the latest now, no?
Yeah, ma'am. Computer assisted counting semen analysis is CASA. ma'am.
Computer assisted.
Automated.
Yeah, it is
analysis.
automated, right. When you call the partner azoospermic, just one semen analysis will do, or you have
No,
to do-
ma'am. Two samples of semen analysis. The second sample should be done after a period of 15 days. In this 15 days, the
15 days, no?
15,
Too
1
short.
5,
No, it's
One-
too short.
4 to 6 weeks, ma'am.
Yeah.
Why
after
4
4
to
weeks,
6
after
weeks?
1 month. Okay. We
Yes,
can't
ma'am.
repeat the semen analysis often. Okay. So after 3 specimens showing no sperms, then we can, it should be done in the same lab or in different labs.
Same
the
lab.
same lab.
Same lab.
Okay. Okay, go on.
General examination, the patient is conscious and oriented, ma'am. The patient looks apparently heavily built and well nourished. No pallor, no icterus, cyanosis, clubbing, and pedal edema. No significant generalized lymphadenopathy. And acne present, ma'am. Vitals, the temperature is afebrile and pulse rate is 87 and respiratory rate is 17 and BP is 110/80 millimeter of mercury, ma'am. Her height is 146 centimeter and her weight is 70 kg. Her BMI is 32.5. So according to the classification, she falls under obese class 1, ma'am. Her waist circumference is 95 centimeter. and acanthosis nigricans present over the neck and axilla, ma'am, and no signs of hirsutism present and no hoarseness of voice.
When all did you look for hirsutism?
Ma'am,
Where all did you look for hirsutism?
according to the modified Galway Ferryman scoring, I will look for the sites like upper lip, ma'am, chin and chest and abdomen, umbilicus, then upper back, lower back, inner thigh and arms, ma'am, inner arms.
Okay.
What is the scoring above which you call hirsutism?
What
More
is the
than 8,
one which- yeah.
more than 8 is called hirsutism, ma'am.
How will you differentiate virilization and hirsutism, hyperandrogenism? Suppose you see virilization features, what will you think?
Madam is
Androgen
asking
excess.
if there is associated virilization, what will you think of?
Any tumors will you think?
What is the other system, adrenal system, what will happen? Somebody is put in the chat box, no? Congenital adrenal hyperplasia.
Congenital adrenal.
So androgen secreting tumors of ovary, late onset congenital adrenal hyperplasia, adrenal tumors. So all this you have to have in your mind when they have virilization features. Okay.
Now, because you think it's PCOS, you tell all the findings, you're telling all the findings in favor of PCOS. Okay. So you're talking about the hirsutism and you're talking about acne and acanthosis nigrans and all that. You're going towards PCOS, but there are other conditions which will also cause hyperandrogenism. Now, you should keep that in mind and try to rule out one by one. Okay. That will be the differential diagnosis, right?
Yes.
Okay.
Yes.
Let's go on.
Continue.
Thyroid appears to be normal, ma'am. Breast examination normal and no discharge noted. Spine and gait normal. Systemic examination CS S1 S2 plus and no murmurs heard. RS bilateral R entry present, no added sound. CNS no focal neurological deficit, ma'am.
Okay, now the breast examination, 1 minute. If the breast examination shows galactoria, what else? How will you proceed? What will you do?
I will evaluate for hyperprolactinemia, ma'am. I
What
will
is the
check for
normal
serum
prolactin
prolactin
levels?
levels.
What is the normal prolactin level? And what is microadenoma? What is the level in microadenoma and macroadenoma?
Normal.
Normal level is 9 to 25, ma'am. Serum prolactin level more than 25 is more than 25 is hyperprolactinemia, ma'am. In microadenoma, the serum prolactin level will be around 20 to 25, ma'am. In macroadenoma, the serum prolactin level may be more than 30, ma'am.
What other investigation you will ask for?
30 or 100.
Ma'am?
What other investigation will you ask for if the prolactin levels are high?
Serum prolactin. Then,
Yes. What other investigation will you ask for?
You said
Now
more
the
than
CD
30.
map to see the size of tumor, ma'am. Microadenoma or macroadenoma.
Somebody is putting in the chat box TSH. Hypothyroidism is important, no? It is associated with hyperprolactinemia. Yeah. Yes.
See, when the prolactin is high, what other conditions will you ask for? To say microadenoma, what should be, how many times the prolactin should be high? Micro or macroadenoma? And what other
More than
cause?
10
Yes.
times.
Okay. You said 30, no?
Yeah, ma'am.
Is 30, you call it as macroadenoma?
Macroadenoma, ma'am. More than 30 nanogram per deciliter, ma'am. Serum prolactin level more than 30 nanogram per deciliter.
So it will be very high. Some other drugs which can cause hyperprolactinemia.
Ma'am, antipsychotic drugs can cause hyperprolactinemia. Ma'am.
So always you ask about hypothyroidism and drugs which can cause elevated prolactin levels, which is more common. Some antacids, they can cause long-standing antacids. They can cause elevated prolactin levels. So always ask about drug history. They are taking some drugs. So whenever you see galactoria.
Yes, ma'am.
Okay.
Okay, ma'am. Okay, ma'am.
Yes, continue.
Yes, go on, doctor.
Yes, ma'am. Abdominal examination, inspection, she looks obese, umbilicus is a midline, inverted, all quadrants moves equally with respiration, no scar, sinuses and dilated veins, hernial orifices free, palpation, abdomen is soft, non-tender and no mass palpable, percussion, no free fluid present, and auscultation, normal bowel sounds heard. Gynecological examination, local examination, the pubic hair normal and genital external genitalia appears normal. First speculum examination, cervix and vagina appears healthy, external loss appears healthy, no discharge noted. Pervaginal examination, the cervix pointing downwards, uterus anteverted, mobile, and size couldn't be made out due to obese abdomen. And fornix is free, non-tender, cervical loss closed, no nodularity felt in the pouch of Douglas, and no bleeding discharge per vagina. Rectal examination, sphincter tone normal and rectal mucosa free. In summary, ma'am, 27-year. Ma'am,
Continue. Continue.
a 27-year-old female married for 2 years came to OPD with complaint of inability to conceive for past 2 years with a history of irregular menstrual cycle and acne and acanthosis nigricans are present and past history of PCOD and no history of contraceptive usage, ma'am. So provisional diagnosis. 27-year-old Mrs. X, married since 2 years, a case of primary infertility, probably due to anovulation for further evaluation. Ma'am.
So what is, why the cutoff of 1 year for primary infertility? What's the reason?
What percentage of women conceive within 1 year of marriage?
80%, ma'am.
80% conceive within 1 year of marriage, ma'am. 90% conceive
What
within 2 years and 98% conceive within 3 years of marriage.
So why the definition for 1 year? That depends on the fecundability of the fecundability. What is fecundability?
What is fecundability?
Probability of achieving pregnancy within one menstrual cycle, ma'am. Fecundability.
So, okay, so that depends, that decides. So within the first 3 months, how many percentage conceives? Next 6 months, 9 months. So within 1 year, 85% will conceive. So
Yes,
that
ma'am.
depends on this fecundability. So they have given this 1 year. Any other age criteria for this 1 year? If it is age is more,
If the female age is more than 35 years, the limited duration of 6 months is only allowed, ma'am. More than 6 months, we have to evaluate, ma'am.
Elderly
more than
who
40,
age
More than 40 years, we have to evaluate immediately, ma'am.
okay, so that's the criteria. So age is above 40, you have to evaluate immediately.
Immediately.
So what
And the
investigations
other
you want to
symptoms
do?
also, like this patient, she has irregular periods, no? So these
Yes, ma'am.
patients, they have to be evaluated earlier.
Yes,
Apart
it's
from the
very
age,
important.
even the symptoms are important. If the patient comes with irregularity and all that, we have to evaluate earlier.
Yes,
We expect
so it
some,
is
Yes, ma'am.
rightly said, because if she comes with symptoms of PID, symptoms of chocolate cyst, so you have to evaluate quick in a rapid manner. You can change those things according to the situation, which is rightly said. So how will you proceed? What are the investigations?
The investigation first, I will order for summary analysis. I will do, ma'am. Then followed by a routine investigation like CBC, then thyroid function test, serum prolactin, RBS, HbA1c, serum lipid profile, then baseline ultrasound. I will do, ma'am. Trans-abdominal and trans-vaginal ultrasound, and the test for ovulation like ultrasound follicular study, FSH and LH in day 2 and 3. LH kit and serum progesterone and anti-Mullerian hormone, Then serum testosterone and DHEAS I will check for, ma'am. Then
With the
followed by I will
anti-malarian
do
hormone, excuse me, how
is
with
a test
anti-malarian
for
hormone?
ovarian reserve, ma'am.
Then why are you telling it is for test for ovulation?
It's for ovarian reserve, ma'am.
So it's not for test for ovulation. Okay.
Test for
So
ovulation.
how will you assess the ovarian reserve?
How will you assess the ovarian reserve?
What are the tests
Ovarian
for
reserve, I
ovarian
will check
reserve?
for serum FSH and serum FSH I will do on day 3 serum FSH estimation, ma'am.
Yes.
Then serum LH,
LH.
serum
LH
estradiol.
is done, no?
See, for ovarian reserve, what are the
Ovarian
tests?
For ovarian reserve, we don't do LH, doctor. We do FSH. Then what are other
Ovarian
things
reserve,
done?
serum FSH and serum estradiol, ma'am.
Yes, estradiol. Then
Then antral follicular count.
follicle count.
What should be the antral follicle count and what should be the AMH to decide the
The
ovarian
antral
reserve?
follicle count of less than 10 follicles of size 2 to 10 mm indicates poor ovarian reserve, ma'am.
10 or 5?
Less than 4.
less than
So
4.
it's 10 then less than 5. Okay. 4 and less.
What should be the ovarian volume, ma?
Ovarian volume should be more than 10, ma'am.
More than 10 or less than 10?
Sorry, less than 10, ma'am.
So what's the
Somebody's put in
advantage
the
of
chat box clomiphene challenge test. What is that?
Clomiphene challenge test on day 3 first we have to do the baseline FSH estimation, ma'am. Followed by we have to give clomiphene citrate 150 mg BD for 3 days. Then followed by we have to estimate the serum FSH on day 10, ma'am.
So what's the ideal test for ovarian reserve? What's the advantage of antral follicle count and
Anti-malarial
AMH?
hormone.
No, what's the
AMH,
advantage
ma'am.
of
What is the
AMH
advantage of AMH?
over other tests or AFC?
It can be estimated on any day of menstrual cycle, ma'am.
So that's
Cycle
very
and it is
important.
independent.
There is no intermenstrual variation. So it can be estimated. That's the more important advantage.
Yes, ma'am.
Yes. What are the other investigations?
Another investigation I will do hysterosalpingogram, saline infusion sonography, or diagnostic laparoscopy with chromoperturbation.
So you think it's a case of PCOS. What else will you do? Apart from FSH, you said testosterone, DHEAs and all that. How about she's on metformin, no? How will you assess the insulin resistance?
I will look for serum of fasting and fasting glucose and serum fasting insulin levels, ma'am.
Yes, fasting insulin has also should be done, no, for this case.
Yes, ma'am.
Okay.
So tubal function test, what is the ideal one? In this patient, what do you prefer?
Question, ma'am.
In this patient, what tubal test will you prefer? HSG or SSG or laparoscopic
HSG, ma'am.
chromoperturbation?
Hysterosalpingography.
So what
No,
is the
doctor,
indication?
see, you are suspecting PCOS, no? So which is the gold standard then?
Laparoscopy, ma'am. Diagnostic laparoscopy.
Both
So what's the indication for laparoscopic tubal patency test? What is the indication? Which cases you select for laparoscopic tubal test?
The indication like ovarian failed medical management of PCOS, ma'am, and if any ovarian adhesions or any adhesion suspected or endometriosis suspected cases, I will do laparoscopy, ma'am.
Okay, any adnexal mass, chocolate cyst, suspected endometriosis, failed medical management. Okay, then so PCOS, when it is resistant to ovulation, then you can also go for a laparoscopy. Why? In PCOS,
Then management, ma'am. I consult the patient regarding the lifestyle management like weight loss and stress reduction. Then female partner should take folic acid 4 mg per day, ma'am. Then treatment for PCOS like weight reduction, metformin plus ovulation induction I will do, ma'am. I will prefer letrozole 2.5 mg per day for 5 days, starting from day 2 to day 6, ma'am. Then followed
Why
by
do you
the
prefer,
lifestyle modification.
wait, doctor, why do you prefer letrozole? Why not clomiphene? What is the disadvantage of clomiphene over letrozole?
Clomiphene will have anti-estrogenic effect on endometrium and cervical mucus, ma'am.
Hmm.
Clomiphene citrate, multiple follicles will grow, ma'am, which will lead to OHSS. But in case of letrozole, one dominant follicle will grow, and there is no OHS is very less in letrozole, ma'am.
Okay, so recent guidelines
I mean the
says for
ovarian
PCOS.
hyperstimulation.
Okay, it's for recent guidelines, PCOS letrozole will be the first line drug. Okay, okay. What is ovulation failure? Failed ovulation. What is the condition called failed ovulation?
Unruptured luteinized unruptured follicular syndrome.
If you have a case of LUF, then what is the treatment for that case?
I will go for a SCG trigger, ma'am.
Who are the patients who are more prone for OHSs?
Young age females and lean habitus and
Yes.
and women with known PCOS, ma'am, and antral follicle count of more than 20 follicles, then serum estradiol level of more than 3000 picogram per deciliter. They will they are prone for developing OHSS, ma'am.
How do you classify OHSs and what are the symptoms?
OHS is classified into mild, moderate, severe, and critical, ma'am. In mild, we will have only abdominal distension and pain only, ma'am. And that is called grade 1. And grade 1 also associated with nausea, vomiting, like that. And weight gain is noted less than 3 kg, ma'am. Then in moderate, in grade 2 OHSS, we have same features like abdominal pain and distension plus ultrasound evidence of ascites plus hydrothorax will be present, ma'am. In moderate, we have clinical evidence of ascites plus pleural effusion,
In grade 1,
hyponatremia,
will you have
hypokalemia,
ascites?
and
In grade 1, will you have hydrothorax?
Ma'am?
Grade 1, will you have hydrothorax?
No, ma'am. No, ma'am.
You said hydrothorax.
No, ma'am. No,
It's
ma'am.
not in grade 1 or 2, it's not. So grade 1 and 2 are mild OHSS, in which you don't
Yes,
have
ma'am.
hydrothorax.
Grade 3 moderate.
Only in severe form, she develops hydrothorax. Okay. Yes.
In grade 4, she developed hydrothorax.
There's high risk of thromboembolism, no? So what is the management?
Yes, the management
Severe
is,
grades, what is the management?
the patient will go for hypovolemia, ma'am. We have to correct the hypovolemia first because the main pathology is increased vascular permeability. So the vascular shift is taking place. So we have to administer albumin 5% in 200 ml oral to administer to correct hypovolemia, ma'am.
So there will be increased vascular endothelial factors. So hemoconcentration, ascites, hydrothorax, all fluid collection in all cavities. And there will be dehydration, hyponatremia, hypokalemia, thromboembolism. It's a very life-threatening condition. So it has to
Yes,
be admitted and has to be treated with albumin, heparin, and needed repeated ascites tapping. So all this. So ovary can also even go for a torsion. So these complications can occur. So you have to be alert when you stimulate the ovaries. She can end in a OHSS. OHSS occurs in which type of ovulation induction? Which protocols? And whom it is very common?
clomiphene citrate ovulation induction, ma'am. It's very common
See,
with the
over,
gonadotropins, ma'am.
in
More with
oral
gonadotrophins,
ovulations,
yeah.
Gonadotropin
oral-
induction, ma'am.
in oral ovulations, only mild form can occur, if at all. Only in
Yes, ma'am.
gonadotrophins, we get
Injectable like
severe form
gonadotropin.
of. So PCOS, elderly age, very high FSH. These people are prone for long protocols. These are prone for OHSS. How will you prevent this?
Prevention during
During
oocyte
the-
travel,
Yes.
we can withhold SCG administration if the follicle is more than 20, ma'am, and the estradiol level is more than 3000 picogram per deciliter noted, ma'am, and we can prevent it by administering albumin 5% albumin in 500 ml oral during oocyte retrieval. We can also administer calcium gluconate 10% calcium gluconate in 200 ml NS during oocyte retrieval, ma'am.
No,
you can
actually,
postpone-
how you, that is, madam is asking, how do you reduce the OHSS in high responders?
Yes.
That is, in case the patient has a previous history of OHSS, then what do you do?
Any change in protocol?
Can we do cycle cancellation? What is the role of gabergolin, dopamine agonist?
Gabergolin 0.25 mg for 8 days given from the day of SCG administration, ma'am. This will prevent OHSS,
What
ma'am.
is posting? Somebody's put in the chat box, posting.
Posting is we can withhold SCG administration until the estradiol level drops, ma'am.
So you can postpone the HCG.
Yes,
Or
we
you can
can.
use
Yes, ma'am.
some other trigger. You can use GnRH. Agonist for
GnRH
trigger.
antagonist, no?
Antagonist.
Antagonist can be
GnRH
used.
antagonist.
You can go for a GnRH antagonist protocol with the
Protocol.
GnRH agonist trigger, or you can use the GnRH antagonist for a trigger. So you can modify the protocol. Instead of long protocol, you go for ultra short, micro. So these protocols you can change so that you can
Or we
prevent
can
this.
go for cryopreservation also.
Yes,
Because the
you can
follicles are
postpone.
there and we can go for a cryopreservation.
Prayer preservation
Because the
and
cycle is
cancellation.
already stimulated, right?
Similarly, when you give oral ovulagens, multiple follicles are formed. You can convert this cycle into an IVF cycle also. So vice versa. You can try both sides, but you have to be very careful that you don't end up in a severe form of OHSS. Okay, next. Other
Yes,
investigation.
Okay, in this case, you have this hirsutism and all that, no? So how are you going to regulate the cycle? She has come with 2 months of amenorrhea, no? That is the history
Yes,
that you
ma'am.
gave. So how are you going to regulate the cycle?
First, I
And she
will.
has-
She's only 27 years old, ma'am. So first, I will prescribe their OC pills to regularize their cycles first, ma'am. Then I will give insulin sensitizer like tablet metformin daily, ma'am, for at least 3 months. Then after that, after regularizing a cycle, I will go for ovulation induction, ma'am.
Okay, you're doing the ovulation induction with letrozole, then how are you going to proceed? What you will do
See
after giving
resistance
letrozole?
or failed. What will
After
you
giving
do?
letrozole, I will do a transvaginal follicular monitoring starting from day 10. I will monitor the follicular size, ma'am. Once it reaches 18 to 20 millimeter size, first I will prefer her to have a natural relationship, ma'am.
Now we have LH kits, no, to find out the ovulation.
Yes, ma'am. We
Find
have
out LH
LH,
surge. Yeah.
LH search kit. It should be started on from day 10 to 11 onwards, ma'am, to detect the LH surge.
You
Can
do
you
it
use
once
LH
daily
kits and
or
what
you do
reference?
it twice daily? The LH.
LH surge should be done on every morning, the first urine sample, ma'am. Once it turns out to
What
be
is the
positive,
half-life of the LH surge? It is only 12 hours, no?
yes,
You
ma'am.
will miss, yeah, you have to do it PD.
Okay.
Otherwise, you will miss the LH surge. So when are you going to
Okay,
give the HCG?
Okay, ma'am.
When are you going to give the HCG, doctor? Done the transvaginal sonography or doing the follicular study, right? Then
Study, if it reaches 18 to 20 millimeter size, we'll administer SCG 5,000 units intramuscularly, ma'am.
5,000 or 10,000?
5,000. First, I will start from 5,000, ma'am.
Okay. Then how are you going to give luteal phase support?
Luteal support, I will give vaginal or oral micronized progesterone support. I will give, ma'am. Or otherwise, I will give SCG 3,000 units after 7 days of first dose, ma'am.
So this you are going to do for how many cycles?
Maximum, I will try 3 to 6 cycles, ma'am.
3 cycles or
3
6 cycles? 3 cycles.
3
Okay.
cycles, ma'am.
Okay.
So
When
it's
3
like-
cycles, she's not ovulating properly. She's not getting the maximum count. Then what are you going to do?
I will increase the dose of letrozole, ma'am, in the next cycle.
Up to what dose you'll increase?
I will, the maximum dose of letrozole is 7.5 mg, ma'am.
What is extended retrosol therapy?
Extended letrozole therapy.
See, you can give from 2.5 up to 7.5 for 5 days. Any day starting from 2nd to 5th day. Or you can
Yes,
go
ma'am.
for extended letrosol therapy, which is given for how many days? For 10 days, from day 1 to
10
day
days,
10.
yes.
Okay. So you can
10
try
days.
this also, which is more effective for PCOS patients. So if it is failed, next what? 6 cycles ovulation induction failed.
Then after that, I will go for IVF.
IVF.
Yes, ma'am.
Why you want IVF? Don't want IVI?
You don't want to try IUI?
I can try, ma'am. IUI.
Then why are you going for IVF? Any say indication for IVF? What is the indication for IVF?
If there is any abnormal tubal blockage
Okay.
and the endometrium related infertility, like
Grade 3,
idiopathic
grade
or
4
endometriosis,
endometriosis, tubal abnormalities. Then
and male factor infertility, ma'am. Immunological factor infertility.
what is the male factor cutoff for IVF?
Anti-sperm antibodies present in the cervical mucus, ma'am.
No, what is the that you can go for IUI? What is the male factor cutoff for IVF? You cannot simply go for IVF, no? What should be the sperm count to go for IVF? What should be the sperm count for IUI? So
For
oligospermia,
IVF, the sperm count, the indication is less than 5 million
so
per
less than 5
ml,
million,
ma'am.
you go for IVF. Less than 1 million, you go for ICSI.
ICSI, ma'am.
So
Yes, ma'am.
oligospermia, you try for IUI.
Yes,
Unless
ma'am.
you have some other morbidities or comorbidities in the male partner. So what's the indication for IUI?
For IUI, madam is asking.
Indication for IUI.
IUI, if there is any anti-sperm antibodies present in the cervical
You
mucus.
didn't tell any test for anti-sperm antibodies. You didn't tell any test for investigation. How will you detect?
SIMS test, ma'am, post-coital test.
Is it valid nowadays? What is the recent guidelines? Is
Not
it valid?
valid nowadays, ma'am.
Then how do you
Not
ask for
valid
a,
nowadays. ma'am.
so any other serological test you can ask for? Sperm agglutination assay. So male factor also you can ask. So any indication for IUI? Oligospermia. See, the count is very less. Then
Okay.
failed. You have failed with all your oral ovulagens. It has failed. 6 to 9 cycles you have tried and you have failed. Unexplained infertility. And you suspect some
Yes.
cervical mucus hostility. Then you can try for your IUI.
Yes, ma'am.
So you have to have some indication.
What is the
Then you go
maximum
for
IUI that you can do for a patient? How many cycles you can try?
IUI maximum of 6 cycles, ma'am.
Okay, you have tried IUI and it fails, then what are you going to do?
Then I will go for IVF, ma'am.
So can you tell some complications of this oral ovulagens? Oral
Huh?
ovulagens. Complications, side effects of oral ovulagens.
Side effects of oral ovulagens, madam is asking.
Ovulation induction drugs, ma'am. Oral drugs.
Apart
What
from
are the side
this,
effects?
what are the other complications?
Multiple pregnancy, ma'am.
Okay. What's the incidence of multiple pregnancy in CC, in letrozole, gonadotrophins?
Mhm.
How much is twins? How much is
Where it is high, ma, in gonadotrophins or clomiphene citrate?
The gonadotrophins, ma'am.
Yeah.
what are the other side effects for clomiphene? What class of drug it is? Clomiphene, what
So
class of drug? Yes.
it's a selective receptor modulator, ma'am.
So what it can cause?
So it will act on it causes thinning of endometrium, ma'am, and alter the cervical mucus, ma'am. Clomiphene citrate.
Okay.
Okay,
It will
what will
block
happen
the
is once you give the drug, what will you advise to the patient? What are the side effects that patient can have?
so that she can come
You
report to
have
you.
to
No?
tell her, no, what all she has to come. She has to report to you. If she has the following, somebody's putting in the chat box,
Some common complications. So that
common complications.
clomiphene acts on estrogen receptors in the brain. So it can produce some complications. Visual cortex it acts.
Yes, scotomas and all that she has to, you have to tell that she can get hot flashes, headache,
Cotomas,
visual
blurring of
disturbance.
vision. So yeah,
Fine.
she has to report immediately.
Okay, otherwise the patient will get scared.
Okay.
So all the side effects you have to tell to the patient while giving the drug.
Yes, ma'am.
Right?
So where does the letrozole acts? This acts on the receptors in the brain. Letrozole,
Letrozole is an aromatase inhibitor, ma'am.
so it acts in the ovary level. Okay. So
Yes,
the HPA axis independent. Hypothalamic axis should be intact. Then only you can give these two drugs. If the hypothalamic pituitary axis is not intact, you cannot use these oral drugs. That's the main difference. So only you classify the WHO 1, 2, 3. So WHO 1, 2, 3 you classify and then you give. If such hypothalamus is not functioning, there's no use in giving your drugs.
letrozole.
So any indication for surgeries in infertility, role of surgery?
What is the role of ovarian drilling for this case?
Ovarian drilling is can be done if in case of the failed medical management, ma'am.
So how do you do
How do you do
the
it?
criteria? How do you do a ovarian drilling? What is the
Ovarian
advantage? What is the
drilling
disadvantage?
is performed laparoscopically, ma'am, by electrocautery or using laser or harmonic scalpel, ma'am. The drilling is limited to 4 punches per ovary, ma'am.
4 punctures, 4 seconds, 40 watts. So that's addictive. So that you don't damage the ovarian reserve. It's
Yes,
a
ma'am.
disadvantage.
What is
Post
the
additions,
disadvantage of doing the ovarian drilling?
the reserve may be decreased. She may develop some post additions,
Decreased ovarian reserve and it will cause peri-ovarian adhesions also, ma'am.
additions, which may be difficult during IVF to retrieve the
Yes,
ovarian
ma'am.
oocytes. So these are some disadvantages you have to discuss. So before planning, laparoscopy, if you plan, it should be a best one and a single one and a first one. The first one should be a best and single. Just like that, you cannot do. So the first one you have to plan, diagnose, and also treat. It should be a best and single one. Repeatedly, you cannot go for a laparoscopy. So you have to plan and do. It's very, very important. Endometriosis, any role for surgery? Chocolate cyst.
Endometriosis, it can also the same laparoscopy we can convert it into a therapeutic. Like if possible, we can excise the endometriotic
Okay, you are
cyst,
excising
chocolate cyst of ovary.
What is the advice you give after endometriosis surgery? For what advice you give? You have done anything? Tubes or patent? You have removed the endometriotic spots, cauterized. What advice you give to the patient when you discharge? About pregnancy, when can she become pregnant? You have to give the advice. No?
After
When can she plan the pregnancy? That's what madam is asking.
after 1 month, ma'am.
So as early as possible, because she has to plan for pregnancy in the next cycle
As
itself.
early as
So will you give any drugs to suppress or to reduce the
GNRH,
endometriosis? Will you give any depot injections or progesterone preparations after surgery?
DMP
Normally-
injections.
Normally, what drugs we give for endometriosis? Medical man.
GNRH agonist I will give, ma'am. Then cabercolin. And recently, dinogestrol we can give, ma'am.
Will you advocate after surgery? So now the recent is we should give a good clearance and ask them to become pregnant immediately, or you have to
Yes,
go
ma'am.
for a medical management before surgery. Okay.
Okay, ma'am.
So any other surgery, indication for surgery in infertility? Uterine causes.
Submucous fibroid, ma'am.
So what staging you do for submucous fibroid?
Okay.
Figure, what is the staging you want submucous fibroid to be removed?
Because staging of fibroid, which stage you will manage submucous fibroid? Tell me the figure staging for fibroid.
More than 5 centimeter present in the endometrial cavity, ma'am.
So 0, 1, 2.
Figure 0, 1 and 2, ma'am.
So if it is a which fibroid, you don't opt for surgery. Subserous, we don't opt initially. Immediately,
Subserous fibroid.
unless it is somewhere distorting the tubes or causing occlusion in the interstitial part. Otherwise, intramural and submucous has to be treated. Any other surgeries? Uterine
If
surgery.
the patient has a tubal block, a proximal tubal block, what do you do? And for distal tubal block, what do you do?
If she have a proximal tubal block, I will go for hysteroscopic cannulation, ma'am, to relieve the block. And in case of distal, I will go for laparoscopic fimbrial tubal microsurgeries in tubal dilatation, ma'am.
Suppose previous tubectomy done, you can go for recanalization. She has lost her babies. Then all she
Oh, yes.
wants is her baby. You can go for recanalization. If suppose she is having hydrosalpinx, if it is a communicating one, then you have to apply
If she
clip
having hydrosalpinx, I will clip the hydrosalpinx before doing IVF,
before
ma'am.
doing this IVF. Okay, so all this you have to plan. If it is a non-communicating, you need not apply a clip. Okay. So these septal resections, someone has posted, very, very important. Uterine abnormalities, septa,
Yes, ma'am.
then you can go for septal resection. Widely
Hysteroscopic septal resection.
widely separated fundus, metroplasty. So these are all some other surgeries you can
Yes, ma'am.
try.
In case you're doing a hysteroscopy and there is evidence of intrauterine adhesions, how will you manage?
And also
I
you
will
tell
do
the classification of
adhesolysis, ma'am.
what is the
Okay.
classification of action, and also you tell.
Okay, ma'am.
Yes.
If adhesions are present, I will do hysteroscopic adhesiolysis, ma'am, and I will insert copper T.
Property, other methods. Adhesiolysis, copper T, then
Then followed by OC pulse, ma'am.
okay, then
Then
you can
high
trace,
estrogen.
you can trace intrauterine folies also for 48 hours. So you have different methods for that. Somebody has posted less than 1/3 is mild form of Asherman's, more than 75% severe
If it
Asherman's.
is 25 to 70%, it is classified as moderate. More than 75% severe adhesion solution, severe Asherman, ma'am.
So you didn't mention about anything about tuberculosis.
Tuberculosis, I just add history only. I asked, ma'am.
How
Like chronic
tuberculosis
cough,
can
fever.
cause infertility?
Ma'am,
How tuberculosis, what are the findings?
tuberculosis most
Histosalpingogram.
commonly affect the tube, will cause salpingitis, hydrosalpinx, ma'am. So the tube ovarian mass also cause, so it will impair the ovum transport and sperm motility also, ma'am. Via the tube, so it will affect the tubal architecture, ma'am.
What are the histosalpingogram findings in tuberculosis? You have some classical
The
findings.
histosalpingography, it's not done in tuberculosis, ma'am.
Not done in active phase.
Active TB, ma'am.
Okay. Suppose you are seeing some active phase or hydrosalpinx, you don't do. Yes, do you have any?
Ma'am,
What are the indications for IVF?
indication for IVF, HRG is showing any tubal blockage, documented tubal blockage in the severe endometriosis, pelvic adhesions.
Endometriosis, ma'am. Poor male factor like severe
Infertility and unexplained infertility.
Immunological infertility.
failed 6
And
cycles of
endometriosis, 3
IUI,
grades of
ma'am.
endometriosis also, no?
Yeah,
Yes,
ma'am.
ma'am.
What are the indications for cryopreservation?
Cryopreservation is done in patient with poor ovarian reserve or patient going for chemo radiation, ma'am, for ovarian malignancy or ovarian sensitive drug radiotherapy patients, ma'am. Cryopreservation is done.
Any surgery, ovarian surgery, ma'am.
Genetic disorders?
Ma'am,
In genetic disorders, what you will do?
Pregenital pre-implantation genetic testing is done, ma'am.
Hmm.
Pre-implantation genetic testing is done to select the embryo with good quality and without any genetic error, ma'am.
How many embryos will you transfer now? What is the latest guidelines?
Only one embryo should be transferred now, ma'am.
Okay. In case you have transferred 3 embryos, is there any role for cytoreduction?
Cytoreduction can be offered to patient with multiple fetal gestation, ma'am. Counseling should be given, and we should, in cases of twin to twin transfusion syndrome and monochorionic twins, cytoreduction can be done. Cytoreduction is done to the twin, which is easily accessible. There are 3 methods for cytoreduction: intrathoracic KCl injection and cord ablation and laser cord coagulation, ma'am.
What are the latest surrogacy rules? Any idea?
Ma'am, latest surrogacy bill was passed in the year 2021, ma'am. Or all surrogate clinics should be registered under the Act, ma'am. Commercial surrogacy is banned and only altruistic surrogacy is approved. The couple should get both essentiality certificate and eligibility certificate from the court, and they should undergo surrogacy, ma'am. It is done for either partner having medical or other causes of infertility, and they should not have any live child or child by adoption, excluding the child with severe medical illness or mentally challenged child, ma'am. Patient can be only surrogate for only once during her lifetime, ma'am. And the surrogacy bill warrants 36 months of insurance coverage for the surrogate mother, ma'am. And couple who is opting for surrogacy should not ban the child born out of surrogacy, and they are considered as legal biological child of the patients, ma'am.
Madam, anything else you want to add, madam?
No, madam. Madam Revati, madam, want
Yeah.
to add anything?
No, they have you almost covered everything. I just want to tell the students that they need not be afraid and hesitant. It is a platform to learn and then discuss. So they are done very well. All points you have covered.
They
Good.
answered very well, madam.
Very good, good.
Thank you,
I think
ma'am.
the students, they
Thank you.
performed very well, madam. Congratulations. And most of the answers are also in the chat box. You can go through. Any doubts you can ask.
Kalpana, madam, expert, IVF expert.
Okay, nice. Thank you.
Thank you, madam.
Thank you, madam.
Thank you.
Just unmute Dr. Kalpana, ma'am. She want to thank you.
Madam Kalpana, madam, you have to unmute. Unmute
No,
yourself.
she's joined now. Again.
She is under mute. She has to remove the mute.
Oh, okay. Just tell her.
Okay, thank you. I'm seeing because I've got another one. Okay, thank you. Bye.
Thank you, ma'am. Bye.
Very nice,
Thank
very
you.
nice.
Thank you, madam.
We'll meet in the next.
Kalpana, ma'am, kindly unmute yourself, please.
You have to unmute. Somebody give a message.
Ma'am, discussion is over, ma'am.
Yes.
Yeah, then we
It's
can
almost
find a
over.
plan. Thank you
I
very much,
thank,
ma'am.
everybody for this, and the students did well. When do you have your exams?
Ma'am, we have our exams in June.
Well, ma'am.
July. Okay, okay. All the best for your exams. And in the chat box, somebody is requested to share the presentation. I don't know share the recording. That's what is asked. So,
Okay, ma'am, we will do that. Yeah,
okay.
thank you.
Thank you, ma'am.
So
Thank you so
everybody.
much, ma'am.
Thank
We
you.
learned a lot from this discussion, ma'am. Thank you so much.
Thank you, ma'am.